I'm Marvin Malek, one of the preceptors for the Northern New England PNHP Health Policy Internship Program. And today we're getting a look at the Medicare program. And we'll start out with how it was set up in 1965. And I'll be including how the benefit evolved a little and uh, other changes that occurred since then. Uh, I think we'll talk a little bit about why it came to be, and I'm going to keep that really pretty quick because it may be stuff that you've heard about earlier in the week. So let me try to get going with the beginning. And I'm planning on adding another slide that's going to tell you who qualifies for the to be in Medicare. And before I do that, I want to say that I'm now going to inject my own personal belief uh, that really, I think you, you could say to a person, why are we waiting till age 65 to be part of Medicare? And I think that question alone, if you talk to a novice, somebody who hasn't given a lot of thought to health policy, somebody who's sort of used to the scramble in the United States and ask them that question, that can generate interesting conversation. So I encourage that as sort of an introduction to get people thinking about how things could be and not only simply accept the status quo, especially given the deleterious effects of the healthcare system status quo here in the U.S. So anyway, it's a good question, and the answer is once you reach age 65. That's the main group that's in Medicare. I don't know exactly when, but blind people got included. I don't know why blind people and not deaf people, but they're not. And then another group that's included are people who are permanently disabled, but only after they're disabled for 2 years. So why they have to wait, I don't know. All this, if today, you may have the question, well, why is such and such included, and why is the benefit like this? And I think in general, the answer is going to be some political process occurred both before and then, after the legislation, the Medicare legislation passed, and it just got worked out that way. God only knows what the backroom, negotiating was all about, back then and even to some extent since then. So the final group added in 1972 are people with end-stage renal disease. Once again, I don't know why them and not the people with end-stage liver or heart disease, but end-stage renal disease. Maybe it was because by then, I think even by 1965, there was already dialysis happening and maybe the beginnings of organ transplant. So, so kidney transplants were maybe getting going around then, and they just felt like, can you deny someone dialysis because they can't pay when they would probably die within, about a week. Anyway, so that all happened, and
Doc, have the slides, are they supposed to be advancing?
no,
Okay, okay.
we
Just
made no progress so far, just talked, unfortunately. So let me move ahead here. I'll at least try to. So again, the whole push for Medicare, which I think you've already heard about, started having work-related health coverage, which has resulted from the wage price freeze during World War II, but the strong union movement throughout the 40s and 50s and 60s to some extent. So a whole bunch of laws passed to allow deductibility, private insurance, and but that left large groups of people not covered, and of a lot of people fell through the cracks. However, the people who did get covered, workers and their families, felt like, well, there's no problem. We have this great, private sector coverage. We're all happy. And so the way the political process worked, you end up with a lot of people falling through the cracks, and many of the people were part of whole groups that fell through the cracks, like Native Americans on reservations, uh, the poor in general, uh, service sector employers like, say, a gas station owner who just couldn't afford private insurance. So poor people, the elderly, uh, veterans before the expansion of the VA, and those are kind of the main groups. So, um, empl- so this led through a long political process, a lot of protests to create coverage in the United States. You got to remember that the big fight for single payer healthcare in 1946 and 1947, the people who lost the fight, in other words, the activists and people who believed in healthcare for all, healthcare is a human right, they didn't go away. They were still fighting, but they ended up having a compromise because the insurance lobby and the doctors lobby were fighting Medicare for all, particularly the doctors who were very powerful at that time, organized through the American Medical Association, the AMA. So they fought it badly, but the pressure to accomplish more and to get people coverage was too overwhelming for the AMA to totally win the fight. So what the ultimate compromise was to expand the VA system, create the Indian Health Service, and more importantly, to create Medicaid for the poor people and Medicare for the elderly, and that'll be the focus today. And again, it was fought pretty hard with Ronald Reagan, the big spokesman. He was paid for the AMA, the American Medical Association, paid him to, paid for these ads to be created with Reagan as the protagonist. And here's Harry Truman sitting the leader in 1946, the president who had fought for single payer universal health care, sitting there when Johnson signs the legislation, and he got the first card to be a member. And I'm there's a story here about Medicare Part A and integration of hospitals. Did Dr. Dolkar tell you the story? Medicare A uh, was a very important part of the civil rights movement, turned out, because Medicare A is the part of Medicare that covers hospital care. Medicare B, outpatient care, particularly doctor visits, both primary care and specialist, labs, x-rays, uh, chemotherapy infusions that are done at the hospital. All those things are in Medicare B. But Medicare A is the hospital. And Medicare A is a universal program once you're in those groups, 65, everybody's covered, and the groups I already mentioned. So they're all in Medicare A, and it was and the year that Medicare was uh, implemented in 1965 was right within a year of when the voting rights and major civil rights legislation passed. And that, and there was a big discussion among the groups that had enacted Medicare about what to do with the Black hospitals in the South and the relatively poor quality of care in those underfunded hospitals. And uh, in this case, a sort of brave decision happened, which was that Medicare A was not going to fund hospital care in any hospital care that didn't allow Black people to use the hospital. And that was at the time incredibly controversial because hospitals in the South, throughout the South, were totally segregated. And this was a major event. And with and they implemented it right away. They really meant it. There was not going to be, they would send out groups, people posing as patients to make sure that this happened, that if you were Black, you could actually get treated. So it actually was implemented in a serious way. And uh, the fact that hospitals were now integrated was really kind of giving the message to people in the South that things are changing, and more than that needs to get integrated too. So it was a major achievement for the civil rights movement. What Lyndon Johnson did to integrate hospital care. But one of the reasons why A and B were separated, with Medicare B being physician care, was Medicare B was at the time was especially doctor care. And there were enough Southern racist doctors in the AMA in 1965 so that the doctors, what's the difference between this waiting room and that waiting room? Anybody want to tell me what they see? Besides the cell phones, leaving that aside. Whoops, sorry. Can't get to it. That one and that one.
Everyone in the first one is white.
Yeah, everybody's white, and the Southern doctors wanted it to stay that way. Um, so Medicare B, the racists won, and doctors were allowed to segregate Black patients. They were exempted from the desegregation order. And that was a result of the AMA lobbying on behalf of the racists who wanted to maintain white-only offices in the South. Just a little history. So now I'll get to Medicare itself. Now, going to the structure of the current program, which will be relevant to further discussion, it's about 21% of total healthcare spending. And the blue in these graphs, the graph on the left is the total healthcare spending. It's 21%. It's 20% of hospital care and physician care, but 34% of retail prescription drugs, which is on the right. And what that's telling you is that elderly people have more prescription drug spending than younger people. They often have more chronic illnesses that require medication. And as a share of federal spending, it's about 10%, with Medicaid being 9%. Medicaid and the ACA subsidies. And the rest of that there are some minor healthcare programs elsewhere, but those are the two big ones in terms of federal spending, which is why people cutting the federal budget have to go after the main areas. If you look at this pie chart, it's Social Security, Medicare, and Medicaid and then defense spending are the only chunks. The rest of them are like hundreds and hundreds of miscellaneous programs that are harder to get much bang for the buck. And when Elon Musk was, had his chainsaw out with Doge, he really had trouble cutting a lot because there were so many agencies and they represented such tiny fractions of overall federal spending. But anyway, Medicare and Medicaid are two little chunks, each around 9 to 10%. And Medicare spending has grown. This is more recent, but it's been kind of growing like this all along, more than, not exponential growth, but it's been pretty steady growth. And Medicare spending does increase with age. kind of levels off. It grows more quickly between ages 65 and 75 than it does later on. As people get older beyond 75 and 80, they kind of don't want to spend their lives in doctor's offices, and they'll let things go untreated, and just they're not going to embark on big, huge elective operations. They're maybe less likely to get like what I got, big shoulder operations. They just may live with their disabilities. But on the other hand, people do accumulate illnesses with age. So there is kind of gradually more spending with age. In the last year, there's a lot of controversy about spending in the last year of life. So this is just an age graph, like total Medicare spending by age. But if you looked at an individual life, in many lives, there's very little spending. And then somebody gets a cancer diagnosis, and suddenly that year they're spending like hundreds of times more, going to many, many more appointments, and with taking many more chemotherapy drugs, or if they got rheumatoid arthritis, suddenly they're getting infusions of things. So often there'll be individual years with huge amounts of spending. This graph is for a population rather than an individual, so it can be gradual. And notice that this is just the years 2010 to 22. And so this is a period of time, and this represents other periods of times too, or both earlier and since, that Medicare is able to cap spending more effectively than the private sector for younger people. And it doesn't do this by reducing administrative costs at all anymore with the privatization effort, which you're going to hear about more later. But it does this primarily by setting fees low. Not as low as the Medicaid ones usually are, but it sets fees low. So for example, I just got a bill. I had a shoulder x-ray, plain film, not a big deal. The bill for it from the hospital where I got done was $546. And Medicare paid 26. Normally that bill would have been about 100 from a normal hospital. I have no idea what that hospital's how they get away with that, but that's sort of the US healthcare system. Anybody can set any price they want to. So, but Medicare has a fee scale, and in this case, I'm really glad they do. So spending on physician care, the Part B, but which includes labs, x-rays, all kinds of imaging and cancer infusions, which, now infusions are going on for rheumatoid arthritis and many other diseases, partly because they're protein molecules or complicated molecules that if you took them as a pill, they would get digested. Because you have enzymes in your gut that digest proteins up, and they break them up and break them down to amino acids and recycle stuff, a lot of it. So when you need to infuse proteins, when you need to administer proteins as a medication, it's by at best subcutaneous and often an infusion. And an infusion that takes place at a doctor offices or hospital, even a hospital, I think, is categorized as Part B. So that's what's been growing. That's the blue in these graphs. And you can see that over time, as a relative proportion of overall healthcare spending, the blue is growing. That's physician care. The green at the top is the relative spending in just inpatient hospital care, and that's not growing as fast. And then I think the gray is Part D, which is the drug benefit, which was added in 2003. And that the reason that even though you already saw graphs showing that prescription drug use is heavy among the elderly and it's not declining, the reason that is declining over time is that these privatized Medicare Advantage plans, many of them haven't encompassed the Part D benefit, and they provide the drug coverage within the Medicare Advantage plan. So the people who have standalone plans are represented in the gray graph. And one of the problems with presenting Medicare data, now that the privatized Medicare Advantage portion of it is more than half the program, half the people in the program, and well more than half the spending, is that a lot of these graphs are data collected in traditional Medicare people who've refused Medicare Advantage. And so this describes, a lot of the graphs can only describe that group because the private sector companies don't share their data, or it just doesn't get included for any number of reasons. So, but let's just go back to support. How is Medicare funded? And what you're seeing here is the graph on the left is total Medicare funding, and that green is general revenue. So it's just revenue coming to the federal government from general federal taxation. But if you look at the two graphs on the right, where that green is really, really heavy, that's the doctor portion, Part B, and the drug benefit, Part D, and they're heavily funded through just general revenue. And the blue in those graphs are premiums coming from the patients. So Part B has a big premium. It's about $2,000. It adds up to $2,000 a year. And so every single person who's enrolled in Medicare B pays that one way or another. If they're very, very poor and they qualify for Medicaid, the Medicaid program will pay that. So anyway, so that's kind of this structure of Medicare B and D, general revenue. Medicare A is a payroll tax paid into a designated trust fund. And there's been a lot of, the trust fund made it into Saturday Night Live in 2000 because Al Gore kept saying, the Republicans are depleting the Medicare trust fund. And, that was a controversy. And George W. Bush did kind of take money out of the trust fund to use it for other things, including a big tax cut. So the Medicare trust fund, lately there's been publicity about the trust fund because the use of the funds, which are the brownish orange ones on the bottom, are growing faster than the revenue coming in. So they got to do something, or the trust fund's going to gradually get depleted over the next 10 to 15 years. And the publicity on this gets into the regular news cycle a lot, and they'll scare people into thinking they won't get Medicare when they're, if they're turning 65 in a few years. But somehow, that, hopefully wouldn't happen. I don't think things are that drastic quite. And again, within Medicare, I already said that Part B spending is growing. Now, I've alluded to the private sector program. It got renamed Medicare Advantage in 2003 when as part of the act that created the drug benefit. So and I just want to say that Part C, you may wonder why we got to Part D, which is the drug benefit. It's not D for drug. It's because before it was called the Medicare Advantage plan or whatever, Medicare Advantage program. It was called Medicare C, but it was a privatization effort. That's what Medicare C was, a privatization effort. And I'll get to the origins of that in a minute, but now it's over. I think it's like 53% of people in Medicare choose or are shoved into a Medicare Advantage plan. But it's well more than half the spending. And we're going to get back to that in a big way over the next few hours. So here's what the average cost is to government for the average Medicare beneficiary. And this cost goes up with age because of the earlier graph we saw, $15,000. Okay, but there is that Part B premium we talked about, which is $2,000 a year. And for 12% of people, the bottom here on this bar graph, 12% of people who are in Medicare, it's a meaningful amount of money. It's more than 10% of their overall income. So it's an issue. And it's really an issue for reasons we're going to get to in a minute because of the structure of the Medicare benefit. And starting, I think in 2003, wealthy people started paying a whole lot more than $2,000 a year. And there's something called the income-related Medicare, I don't know, some adjustment, something like that, IRMA. And the wealthier people pay a lot more than $2,000 a year. So that happened. Now this is a complicated graph, and you don't need to know the details here, but we're going to spend a little time on this because this is number one important concept to understand about Medicare. And what's going on here is that Medicare's coverage is terrible. It's terrible. Part A is the hospital part of it, and you don't have to pay a monthly premium. This is the good part. If you've worked a certain amount, like 10 quarters in your lifetime, which means 2.5 years, and most people have. So that really helps the Medicare A benefit to be not something other than really terrible, because the standard, and then there's an adjustment for how many quarters you worked, which most people get to if they've worked throughout their lives. And so there's a certain premium, and it's not onerous to people who have any form of supplemental coverage. But what is noticeable is that for the second part of that thing where it says inpatient deductible and coinsurance, that you pay if you're hospitalized in January and you don't have Part A coverage because you didn't work for 10 quarters in your lifetime, you pay a $1,556 deductible for each benefit period. Now, normally, when we talked about deductibles, that's your deductible for the year. So you pay that deductible, and then you're good for the year with most insurance. But this one, I don't know why, but this one, it's the deductible for 2 months, and you start paying $1,556 if you get hospitalized in March, 2 months later. It's really terrible. This is a really incredible lack of benefit here, or whatever, if you want to call it a benefit. And then if you're in the hospital more than 60 days, you start paying $389 per day for a bunch of days. Now, most people aren't hospitalized anymore for more than 60 days, but it could happen. I don't know. It's at least possible. And so that, you would have huge bills. I don't know what this is all about, because even back then, hospitalizations for more than 60 days were far from common. But it's just pretty weird that they stuck this in the benefit, and I have no explanation. Part B is actually nowadays a much bigger problem because most people meet that work requirement. And that, just to go back to Part A for a second. So the big problem for that Part A is immigrants, because they may really not have gotten to work 10 quarters. So there are people who are immigrants who are paying a whole lot for hospital care, even if they've become citizens. So in other words, if somebody came over at age 64, they wouldn't have worked for 10 quarters. Anyway, so it's a problem for those people. And but just to say something about immigrants, so one of the requirements for becoming an immigrant and being allowed into the country is, and I don't know the details, but you're not allowed to take Medicaid or need public benefits. And so one of you may know better than me, but I don't know if I know Medicaid and welfare are in that statement. You can't get on Medicaid at least right away if you're an immigrant. And I don't know about Medicare for people who are immigrate over age 65, but I wouldn't be surprised if there's a period of time where you have to wait. Be interesting for someone to look into that. Anyway, Part B is a much bigger problem because this is not just a problem for a small minority of people who haven't worked their entire adult lives. This is everybody. And what's going on here is you pay the premium, $185 a month, it's $2,000 a year, 2,200. And and then there's a deductible, $257. That is what it is, not terrible. It's just another $200 so to use the insurance. But it's what happens after that that is really, really significant. This is critical to a whole lot of other things that occur in Medicare. After you pay your $257 annually to use your Medicare Part B benefit, after that, you have co-insurance at 20%. So if you get an x-ray, you pay 20%. If you go to a doctor's primary care, 20%. If you go to a specialist, same thing. Every lab test, you're going to pay 20%. So this goes on and on and on. Cancer infusion, cancer treatment, 20%. And if you have cancer or you got some multiple sclerosis, some expensive disease, this gets expensive real fast. And critically important, there is no cap. If you hit $8,000, you keep paying. You hit $20,000, you keep paying. It never ends. You keep paying those bills, 20% of every single one. And this is why people want to get supplemental, some sort of additional coverage. Because that cap is frightening and that cap can bankrupt your family. So this is really important, and this makes the the Medicare benefit, from my point of view, really pretty crappy. And this is a battle that needs to be fought. And this is a battle that, for example, PNHP, National Nurses United, and many senior groups fight. Why is this structured this way? We want a better benefit. We want traditional Medicare to maybe cover things like dental and eyeglasses and hearing aids and all that, but we really want to get rid of this 20% co-insurance. So this is a center point of a battle. And so people buy something called supplemental coverage, and that 20% didn't just become a problem as healthcare costs got worse due to healthcare cost inflation. But it was bad enough that private insurance companies noticed this 20% co-insurance, and they were able to start selling policies to cover it by 1966. Because nobody ever wanted that 20% co-insurance looming over them. So here's a graph of what people do to deal with that supplemental coverage, except it excludes Medicare Advantage. And the big reason people are signing into Medicare Advantage is because it'll cover that 20%. But for people who don't have Medicare Advantage, this is what's going on. In 2016 rather, 10 years ago, I wish I had an updated one, but I can tell you generally that it's mostly the same. But what you got here is the upper part of this is 30% of people have retiree health coverage that was paid by an employer who presumably had them as an employee for long enough to provide reasonable retiree health coverage. And I got to tell you that 30% you're looking at the top, that's a dinosaur. That may even be cut in half by now, but you guys, when you get to age 65, I don't know if you're going to know even 10 people who have retiree health coverage to cover this 20% co-insurance. Employers are pulling back on that, and it's going. The only employers these days who even have a shot at still covering it are like public sector jobs where there's a good union that's really fighting for its workers. And some insurance companies have so much money that they provide that retiree health coverage. there may be others, companies where there's a real labor shortage of highly skilled workers. Maybe some tech industries where they really need highly skilled workers who might be promising retiree coverage, but I mean, that's going away. So then the next one, the blue, the darker blue, is people who pay for Medigap coverage, and that's growing to some extent. I'm in that group. I pay, and what it's worked out to in terms of how much I pay and how much most people pay to get supplemental coverage is $2,000 a year, similar to the Medicare B benefit premium. So in other words, I pay $4,000 a year to get pay the Medicare B premium to the government and pay a private insurance company for supplemental coverage to cover it at 20%. And some of the odds and ends that were also on that other thing from Medicare A. And that's important to me because I don't want to have an unlimited liability in case I actually get sick. Okay, so the light blue is Medicaid. So those are poor people who are over age 65 or permanently disabled and poor, and so they qualify for Medicaid, and Medicaid will pay for the gap coverage. And then you got 19% of people who have no supplemental coverage. So these people, you can use your imagination. They're facing the whole 20% co-insurance thing. So they're really hoping they don't get sick. And that 19% would be growing, except for one other development, which is the privatization initiative. But I'll just mention quickly Part D was added in 2003, and it's the drug benefit. And it was put in an administration that was neoliberal in philosophy. They wanted everything possible privatized. So instead of the government just providing the benefit, negotiating with the drug companies over costs and paying for drugs directly, they subcontracted it and left it open to any number of insurance companies to provide the benefit. And so it's balkanized into private insurance companies, none of which has much market power to get the prices down or for the drugs. And we end up with the highest drug costs in the world. We had it before then, we still have it. And they created a very complicated benefit where if you went beyond $4,000, you had to pay 100%. That was called the donut hole. That subsequently, just in the last few years, that got changed so that now there is a cap and it's $2,000. So if you buy the drug benefit, which I do because I want to have drug coverage, if I actually started using a lot of drugs, there's co-pays and all of that. And finally, if I've paid enough money out of pocket to get to $2,000, the government, the Part D, would pay for it. And that, again, you may recall that's general revenue and premiums that pays for the Part D program. This guy, by the way, was the head of the Medicare program at the time it was created, and he spent all of his professional life, both before and since, working for a drug company, Eli Lilly. That's Alex Azar. And this was the guy who designed the drug benefit. He was a representative from Louisiana. His name is Towson. And he got the bill passed in 2003, and within 1 year, he took a $2 million job as the chief lobbyist for the pharmaceutical lobby, Billy Towson. So that happened, kind of revolving doorish. And here we have the growth of employer-sponsored insurance for young people in the US. And what you see here is that by 1980, it was 145 million people. And it peaked during the Clinton boom economy in the year 2000, before the 2001 economic crash, and then even worse by the 2008-9 economic crash. And so by 2019, you have around 160 million people that have private coverage. So this is half the population. They're under age 65 almost exclusively. So what you're seeing here, now I want to look at this from the point of view of the insurance industry. So this is known as a fairly stagnant market. They're not their product is too expensive for additional people to afford. So they hit about half the population of the United States and plateaued. So earlier on, in 1965, when Medicare was passed, they were thrilled. The government was going to pay for the really expensive people, those who are over 65. So the insurance industry was well on board with that in 1965. But starting in 1985, the insurance companies started to say, well, not everybody who's over 65 is unhealthy. And they started thinking, well, maybe we could pick them off too, pick off the healthy elderly people. So, because they know this. This is the most important bar graph you're going to see in this internship. So let's go over it a little. This is a decile graph. Each bar represents 10% of the population. Over on the left is somebody who's really healthy. And bar 1 and 2 and 3 are really healthy people. And even going all the way over to 5 and 6, those are healthy people. They cost the healthcare system almost nothing. But somebody with multiple sclerosis is going to be over on the right, or cancer, and they're going to cost a whole lot. And there's kind of two flavors of people who are on the right, the 10% of the population who need the most costly care. There's two varieties. One is the people who have multiple sclerosis, who are going to have the disease for probably the rest of their lives, and they're going to be expensive every single year. They're just going to cost a lot to whoever's going to pay. And on the other hand, there are people who go there sometimes. So somebody needs like a big shoulder operation. Like, I hope I can be back on the left side of this graph again, but this year I'm expensive. So, or they fall, they take a bad fall and they're break a lot of bones. So that you can be there temporarily and have a bad year, which is why people like to have health insurance, even if they're healthy. And so there's kind of two general varieties. But basically, the insurance companies know about this. And enough people are always there so that they know they don't want them. They want to not cover those people if they can get out of it. And so in 2003 to 2006, as this new piece of legislation that called Medicare Part C the Medicare Advantage plan, they were able to do a variety of strategies to pick off healthy people. And it was clear very quickly. For example, I'm going to ask you guys, if you were the marketing executive within a private health insurance company, and you were going to try to sell your new Medicare Advantage product to elderly people, how would you market it so that sick people wouldn't want your policy and healthy people would want the policy? Where would you send your promotional material?
Like direct, like where, like businesses or like on like TV? Is that what you're asking?
You're saying
Maybe
you promote it to businesses who may still have some employees over age 65. And you're
that,
thinking that they're working, so they're probably kind of healthy. Is that?
yeah, yeah, that or like if I were to do like ads over like the internet or TV, it'd probably be to like more affluent people, just assuming they've had some sort of health insurance to keep them healthy over their lifetime.
Well, the internet's a good strategy because the poorest, sickest, elderly people may not be able to get on the internet. You know, it takes a little learning to figure it out. And so that'll probably get rid of the very sickest people and people with like Alzheimer's who can't get on the internet. So you could get rid of them, or stroked out people. So the internet would work. You know, I don't know about television because that generation watches a lot of television. So anyway, any other thoughts on what you would do to try to attract healthy people?
I don't know if this is the direction
Yeah.
you were looking for, but like healthy seniors might still be like active, so they might belong to like I don't know, some sort of clubs. Like I don't know, pickleball is very popular these days.
Yeah,
So
that's
I don't
great.
know, those spaces.
Yeah. Anything athletic gonna work. That would be good.
Maybe also if they can get addresses of seniors living by themselves rather than in like a nursing facility or like a care home.
Okay, very exactly. So the biggest thing you're not going to do is advertise in nursing homes. You are not going to do that because those people have a whole lot of comorbidity. They got lots of illnesses going on. So this is the kind of thinking that goes on when you're trying to recruit healthier people. There was a Medicaid. Okay, so Medicaid got privatized too. We'll talk about that tomorrow. One of the things they did, those Medicaid subcontractors, um, was they would put their office on the second floor in a building with no elevator. They would have it so that you had to have relatively high language ability to to be able to sign into the coverage and prove that you understood it. Just the kinds of strategies that have been used to try to avoid sicker people has been almost heroic by the companies. Anyway, I want to just stop a second, and I'm not sure I even explained properly what Medicare Advantage is doing and what privatization in this context even means. So let me just say that. It'll only take a couple sentences. So Medicare A provides hospital care. Medicare B provides all the other services I mentioned, doctor, lab, all that. And and what and the providers are paid directly. The money goes in Medicare Part B, the money goes from Medicare B and from the private insurance company the patient hopefully has if they've paid for it. The money goes from those sources directly to the doctor or the x-ray place or the lab that's doing the lab test. It's a direct payment. Privatization in this context means instead of the money being paying the doctor or the hospital directly, the money instead goes only to an insurance company that's signed up and registered as a Medicare Advantage plan, previously Medicare C. They get all the money prepaid once a month. And you saw that $15,000, the average cost per Medicare beneficiary. So it would be 1 month version. So, whatever it is, $1,200 every month would just go to the Medicare Advantage company, and they then pay for everything. So you're inserting a middleman. That's what's going on with this insurance privatization. And then you might ask, well, why would you do that? I can't explain it in a better way than this was not the result of a social movement. This was the result of a lobbying effort. There was never a social movement to say, I want Medicare privatized. So this is a lobbying effort. The insurance companies wanted this population because the younger market was stagnating. And so that's what the origins of the Medicare Advantage or Medicare Part C program. Its origin was in lobbying, not in a social movement, unlike original Medicare. So in 2006, the government finally responded to the fact that they were only picking off healthy people. And they created a system where you get paid more if a patient had heart failure than if they didn't. And we're going to get more into that later. And there's 3 ways people get into Medicare Advantage plans. The big part of them, it looks like about 70% maybe, are people who just signed into one. And the other 2 are people, the orange one is people who got shoved into Medicare because they had retiree health coverage and they're now retired. And the company that is paying for that retiree coverage got tired of paying more and they wanted to pay less. So the amount of money they have to pay to get you into a Medicare Advantage plan is lower than what they can expect to pay if you have a la carte coverage. So these employers that are kind enough to provide retiree health coverage are shoving their employees into Medicare Advantage plans. And for those of you who live in New York, in or around New York City, there's a huge battle from one of the big unions in New York City about being shoved into a Medicare Advantage plan because they didn't want it. And so that got a whole lot of attention. The other one are special needs plans, and these are people who are pretty badly disabled or even live in a nursing home or are at home requiring tremendous amounts of care. And these people get the largest amount of money to the private sector insurance company that's going to get to take care of them. These are big bucks per person, and the insurance companies lobbied really heavily to be able to cover these very sick people because they have the power to deny care, and those people need a lot of care. So these are by far the most profitable group, are these people who are chronically ill. And at first they didn't want them. But now with these risk adjustment schemes that began in 2006, now they can actually make a fortune off of them because they're getting paid so much. So that was sort of the downside of Medicare's response in 2006 to them just picking off only healthy people. Now they're adjusted for sickness, and they can really game that. This is back to the thing about group plans. People who are shoved into Medicare Advantage through a retiree health coverage, and that's grown. And these are the special needs plans I was just talking about. That's growing too. It's not so much growing because the number of people who are totally disabled like that is growing that much. It's because the government is paying more and more. It's become lucrative. And there's been a lot of cracking down on cheating, and you're going to hear more about cheating in a minute. So here's total spending on Medicare Advantage plan. These are just bonuses. So the formula that pays Medicare Advantage allowed them to get a bonus if they provide high quality care. Anybody want to guess how high quality care is measured? Like a Medicare Advantage plan is an insurance plan. It's not a doctor. So how do you measure quality of care for someone who's not even a doctor? Like how would you want to assess the quality of service of a Medicare Advantage company?
I was gonna say, maybe if they've approved some claims and paid out certain services, but then over time the services from patients have decreased. Like people are filing less claims.
I'm not sure I understand that one.
Like
The
people
people are
are,
getting
are
healthier?
going less. Like they might have initially had an operation or had a bunch of appointments one year and then the following year they don't follow up as much. So they're spending less on that patient.
So
I
that
don't know
would
if it makes sense now that I'm
demonstrate
saying it out loud.
success?
Yeah, maybe.
Okay.
I guess one thing that I would put in, just because I do have the ability to deny care, is like what percentage of claims goes through, just in general, and then
The
I don't know.
percent they deny
Yeah,
is, you would
if
say
it
that's bad?
yeah, if it's like I'm sure there's like comparator, like even from like private health insurance, if they're able to set a benchmark and if they go over that, then they
Okay.
get less money.
I like that one. It's not in there, but I like it. I like it a lot. In fact, that would be number one on my list. The insurance companies that denying high portions of the claims, I wouldn't I would view that as not helpful to me as a patient, and I wouldn't like that. But that's not measured. Any other thoughts?
Like direct patient outcomes, like life expectancy on Medicare Advantage versus traditional
Yeah, so
Medicare.
you're getting back to how the patient does health-wise. That makes sense. And the problem is how much impact does a Medicare Advantage plan or even any insurance company have on mortality? We talked about that the other day. It's around, 10 or 15% at best. And how much difference will there be between a Medicare Advantage plan and other? So it's kind of a tough one. It's the ideal one. It's the ideal measure for a provider of care is outcomes. And death would be, it's an easy outcome to measure. Hospitalization rate would, could be on that list. Then there's like hospitalizations for conditions that are the most preventable hospitalizations, like asthma. If it's treated properly, most people don't need to be hospitalized. So you could look at death or, avoidable, preventable hospitalizations. So that could be done. And it's good, that's fine. And they may even have that, preventable hospitalizations. I think they do have death from suicide because that's felt to be more preventable with medical care. And another reason that's in there is because these companies have been notorious at denying mental health care. So they figure, well, suicide rate might get at that if you didn't let people get mental health care. But I mean, I guess the point I'm making is that it's not easy to measure. And Zach's measure, which is the really one everybody would want to know, are they letting me get care? That's not in there. It's just the kind of stuff, the other ones that you were measuring, which is trying to measure actual patient outcomes. But they don't have that much impact on that. So what this ends up being is a bonus that tradition I pay in traditional Medicare. I pay my premium to Part B, for 185. I pay more because I'm in a higher income group. So I pay, whatever, $3,000 or $4,000 a year just to Medicare B for my premium. And I don't like that this money is diverted to the Medicare Advantage program, to these profit-seeking companies, and they're supposed to use it to give extra benefits, which they do. And I don't get those benefits. It only goes to them. There's no bonus in traditional Medicare. These are all extra payments going to Medicare Advantage insurers only. They don't get to me at all. So this is a little part of the empire of extra bonuses that go to Medicare Advantage plans. And I'd like to stop here. And after a break, we can switch over to James Waters, and I'm going to try to play his video.
I have one question about ACA marketplace plans.
Yeah.
Are those at all considered like employer sponsored insurance plans, or are those fall under Medicaid, or how are those classified?
It's a great question. Marketplace plans came into existence with the Obamacare legislation in 2009, and they are kind of specifically the opposite of employer-sponsored plans.
Okay.
These are for people who are falling through the cracks in the system. They're not poor enough to qualify for Medicaid. They're not old enough to qualify for Medicare for the most part, and well, really entirely. And they can go on these exchanges and get an insurance plan. And if they're relatively low income, there will be subsidies coming from the federal government through the Obamacare legislation. So my nephew owns a small business, and he absolutely cannot afford the local health insurance coverage for his employees to provide coverage for his employees. It's a very small business. So what he does is he says, well, I'm not providing you coverage, but I'm going to give you a bunch of money if you get on the exchanges and get your family a plan. And I think he pays his employees too much for them to qualify, which would be $88,000 a year, or it might have gone up to 90 or 92. So, um, the, so he's encouraging them to get onto the exchanges and the Obamacare thing. And if they were poor, they would get subsidized by the government. So in some ways, you can think of the Obamacare exchanges as being similar to Medicare Advantage, where the government is subsidizing the purchase of private insurance. In Medicare Advantage, they're subsidizing the purchase of these private Medicare Advantage plans. In the Obamacare exchanges, they're subsidizing individuals to purchase a private insurance plan. And the appearance on the market of private insurance plan is up to the insurance company. If they are going to provide that nice, semi-comprehensive benefit package where it's got substance abuse coverage, mental health, prescription drug, the whole list. But then there's terrible copays and deductibles. Terrible. I mean, they're really bad. But I think they do have a cap, unlike Medicare B. So they're terrible because of high copays and deductibles, but in Medicare B is terrible because there's no limit. There's absolutely no cap on that 20% coinsurance. So they're both fairly bad coverage. However, you can get, if you're heavily subsidized by the federal government, almost qualifying for Medicaid because you're really kind of poor, it becomes not so bad, and it's reasonable coverage. So that was the niche, was this the group that didn't qualify for Medicaid but are still kind of poor. And then there's the angle of what my nephew does, of subsidizing. He can't afford a big policy, to buy an actual policy, but he gives them money to at least get some kind of coverage.
Okay, cool. Because
That was a long answer because it's an important question.
yeah, no,
Sorry the answer was so long, but
that was very helpful. I was confused because I know a lot of people work and have like an ACA marketplace plan, so I didn't know if the employer directly contributed to it, but it seems like it's like it helps obviously the person get health insurance, but it also helps the employer not have to bear as much responsibility if they can't afford it. It's like the whole neoliberal thing about like the individual has an obligation to get health insurance is kind of what it seems to support, but it also benefits their employer because they don't have to pay for their health insurance in a way.
well, yes. Yeah, it benefits employers, particularly those who are not. So if you, okay, so if you're paying your employee like a Walmart wage, a fairly bad wage, but enough so that they don't qualify for Medicaid, then these people would be heavily subsidized, just say just above Medicaid eligibility level, but and then they get big subsidies from the government. So you could call that sort of corporate welfare. Government in those cases is paying to keep people healthy while the company is contributing nothing to the healthcare system at all. Except whatever taxes they pay, which in the US have been lowered a lot. So
Okay. So it more
yeah,
so helps the companies is what you're saying.
yeah. And in the case of my nephew, that's voluntary. He doesn't have to do that. He could just be one of these companies that provides nothing. But he sets aside this extra money beyond their salaries, and because he wants their. I mean, people want their employees to be healthy. They don't want people to be out of work all the time ill. So it's in the interest of employers to have healthy employees. Especially a lot of it's mental health care too at younger ages. Where people are just grappling with issues in their lives. Depression or anxiety or situational marital issues, and to to keep people productive at work, they need to sort of be functional. So anyway, it's beneficial to employers, but a lot of them don't pay anything. And in the case of my nephew, he doesn't give enough to give him a real full policy, but it's enough to motivate them to want to get in the exchanges. Yeah, it's a good question. So I'm gonna suddenly, after 2 years in office, Biden's CMS put out this press release. It was like truly bizarre. It said, these Medicare Advantage plans are cheating, and they've been cheating since 2007, which is basically when the cheating has to do with this making patients sound sicker than they are. Making patients appear to be sicker than they are is incredibly important, and that's the primary strategy they're using to bilk taxpayer money out of the Medicare Advantage program. So they did an audit to see if they were making patients appear to be sicker than they really were or are, and in every single year that was happening. So they said, consequently, we're going to pay less, meaningfully less, and to each year to these Medicare Advantage companies. Furthermore, we're going to go back at least 5 years. We're not going to go all the way back to 2007. We're going to go back 5 years to 2018. And we want the money back from the overpayments. It was like, I read this press release and it was like, oh my God, what is this all about? Like, what happened to Biden's CMS? And this set off a flurry of lobbying, the likes of which I don't know, you didn't hear about it, but there's something called the Better Medicare Alliance, which is AstroTurf, meaning it's an industry, totally 100% industry funded by the insurance industry. Yeah, so they certainly are the leading voice for Medicare Advantage. And they put out this whole thing. And so CMS pretty much gave in, and they said, okay, we won't claw anything back from previous years. And they ended up paying them almost as much as they had been accustomed to paying. So, this is the Washington that we're in now, and it needs to change. We'll talk another time about whether it can, but but the whole thing is so profitable that like now we're 2025 that I personally had 36 plans to choose from. Had no idea, how anybody would go. You're given no information to make the choice when you're signing up. Each year there's an open enrollment period, no information. So it's so profitable, everybody wants in. And obviously this is becoming most of Medicare spending is becoming Medicare Advantage, both because now we're up to 52 or 53% of people in it, and they're getting overpaid so badly. So they're sucking all the money out of so much money out of Medicare. Anyway, so payments are very high, and we already talked about narrow networks, and this is just huge amounts of money and going this way. So I wanted to go over 10 reasons people are drawn to sign up. There's a lot of hyped extra benefits, gym stipends, and one of you guys suggested pickleball, but other kinds of gym stuff too, to encourage people who are athletic to get into a Medicare Advantage plan. And they give them debit cards to buy Tylenol or things that might not be covered. And then vision and hearing aids, and the benefit turns out to be very limited. And they've been studying this now, and very few people actually take care of the extra benefits. And then Part D premium. So since I don't want to be in a Medicare Advantage plan, I pay Part B premiums. Everybody in Medicare pays that, but I also have to pay Part D premiums. And they've been rising particularly rapidly. They really have been in the last couple of years. And then I pay, as I said, $2,000 a year for supplemental coverage, so I don't have to deal with the 20% co-insurance in Medicare B. But Medicare Advantage plans are getting so much extra payments, and I don't think James said this, but out of the $140 billion of overpayments, some of it goes back to lowering their premiums. They don't keep it all as profit. They are giving the consumers, they're, the Medicare people who sign up, they're making it really cheap to get into Medicare Advantage and, have hospital care and all that's provided. So it's, there is this is an important reason. This is the reason people go in. They're getting hospital care covered. May not be the hospital they want to go to, and they may not be allowed to go to a cancer hospital if they have cancer, but at least they get into the hospital, and whereas with leaving 20% co-insurance for Part B, meaning that all the doctors who see you in the hospital, you would be paying 20%, of their fee, even if you are in the hospital, and then all the specialist care, they don't want the 20%. So to get into a Medicare Advantage that's going to provide some coverage, even if there are copays, it's just not 20% generally. And there's a cap. Medicare, they now have an annual cap on spending, which is $9,350. I mean, that's a lot, but it's not infinite like it is in traditional Medicare. And it's simple. Like, I had to sign up for A, B, and D and get supplemental coverage. It's complicated. I had to do 4 things to get into what I have, in Medicare. And it's complicated, whereas a Medicare Advantage plan, you sign up one thing, you're in. So the other 5, heavy promotion advertising, possible penalty for switching out. If you're actually getting sick, you probably will get a penalty when you try to buy supplemental coverage, after getting out of a Medicare Advantage plan. James talked about that. And then employers are shoving people into it. The employers that provide retiree coverage, they get a better deal. And James talked about higher payments to insurance brokers. And then nobody talks about the issues with Medicare Advantage. They don't know that they're not going to go to a cancer hospital, So there's a lot of good reasons people are signing up for Medicare Advantage plans. Let's see what this is all about. Oh, so James mentioned denials of care. And so just the most recent research on that done through Kaiser Family Foundation, and found that the total number of denials of care, no, the total number of requests from doctors for prior authorization in 2023 was just under 50 million. Now, James mentioned that they're rare in traditional Medicare. They do happen. 20 times less. So the average person in a Medicare Advantage plan their doctor will have to do 2 prior auths a year, and in traditional Medicare it's 0.1. And I have to tell you that some things that doctors want to do really are sketchy. 0.1% of doctors probably are really pretty sketchy, and they're asking for things, or the patient says, I want this, please order it, and the doctor gives in. The doctor knows it's not going to be approved, so, just putting it in to keep the patient happy, and it gets denied. So there are denials, but it's 20 times less common. Anyway, so 50 million prior auth requests, and the patient does not get that treatment if the doctor doesn't do it. So the doctor has to do it to keep their patient happy and feeling okay about them. So out of the 50 million, 3.2 were denied. So that's a rate of around 6.4%. So that sounds like, well, it's an extra procedure, but the patient, for the most part, still gets the care they need. 3.2 million denials is actually not such a low number. And only 11.8% of the time do people fight. But if they fight, they win, because what the insurance company's doing is so often completely out of the blue and unreasonable. So this slide, this is very disturbing. This data is also out of Kaiser Family Foundation. They did a compilation. And this is a real problem. And going back to the 50 million, so 50 million times a year, when a doctor's in their office trying to treat patients, they have to interrupt their day to fill in a prior authorization request. So they're trying to fight back with AI, and the insurance industry has found a way to fight back against using AI to kind of help with this. But this is the kind of nonsense that goes on. And for the doctors, especially in primary care where a lot of this happens, this is going on in their evening. They can't really interrupt their schedule because schedules usually get packed. So, yeah, these are real issues. And it's just very frustrating to have to deal with this, and you're powerless not to. I mean, if you get a prior auth request, you have to do it. If you're online for it, you're their main person. And so I don't know. Anyway, so I hope that this gives you at least the beginnings of understanding of a needlessly complex program that is flawed. And I want to ask you guys definitely one question one thing to think about, and I'd like to hear you guys talk about a little. So Medicare is really flawed, and there's a lot of out-of-pocket costs. The people in Medicare Advantage plans really do pay a lot of money. Every time they go to a specialist, they're paying maybe $50 or $100, up to the 9,300. But I mean, most of them are paying less. They end up with out-of-pocket payments, maybe of $200 or $300, $400 a year, maybe more. But and in traditional Medicare, you have to buy these. I don't pay any of that stuff, but I paid an extra $2,000 a year to get a Medicare supplemental plan, whereas the people going into Medicare Advantage are averaging $400 a year. I'm paying $2,200, and then I pay another $300-400 to get Medicare D for drugs. So I'm paying all that money up front. The Medicare Advantage people are only paying $400 or $500, or even zero in some zip codes. This is all determined by zip code. It's incredibly complicated. So why is Medicare so popular? This is, to me, this is so interesting. Why is Medicare so popular? PNHP, you and all the activists like me, we're always talking Medicare for all because nobody knows what single payer reform is. So Medicare for all is kind of sounds better, but why is it better? Like, I, my answer to that question lay in your session yesterday when you were doing your interviews with family members. I think that's where the answer is. That as crappy as the benefit is, I guess it's not a scramble. It's there. You turn 65, it's there. I don't know. What are your thoughts on that? Yeah, go ahead. Caitlin, is that Caitlin?
Yeah. So something that immediately comes to mind from one of the talks from yesterday was that um, it's been found that Medicare makes Americans healthier. And although it may not be perfect, one of the statistics that does stick out is that colon cancer screenings and mammogram screenings increase after people get on Medicare, and also that one figure that shows once Americans reach the age of 65, the kind of quality, I don't remember what it was, life expectancy or quality of healthcare goes to basically the top, whereas before it's ranked the lowest among other countries.
Yes.
So I think that although Medicare is imperfect, it does make Americans healthier, and it does just provide very high quality healthcare. It has that ability. So
Yeah, go ahead, Natalia.
I think from like a layperson perspective, something that would be compelling is just that like you've been paying for this your entire working life, so it feels like you deserve to like get the benefit of being part of the plan. So it feels like a waste if you don't use it.
Okay, Zach?
Um, I recently had to navigate this process, so I have a little bit of sympathy for you, Dr. Malik. But what my grandparent personally focused on is like she's had already a lot of negative experiences with private insurances. So like her lifetime of like having to deal with like prior authorizations or whatever, she's like, if granted, she, like you said, she does have the ability to pay the increased cost for like Medigap and Part D, but she was like, if I never have, she focused on like kind of like being a burden, like especially as she gets older. If she's not willing to call the insurance company to fight the prior authorization, then someone else is gonna have to do it for her. So that was a big part of it. And then also, I'm assuming at 65, I think you're just automatically put on Medicare. So people that just like abstain from making a decision are automatically enrolled, and I'm sure that's a significant amount of enrollees as well.
Well, that needs a response. Here's what actually happens. You are semi-automatically enrolled in Part A, the hospital care, but you're not enrolled in Part B unless you do something. And if people really do nothing, they really won't be in Part D. And furthermore, if you don't, I think if you wait a full year and not sign up for Part B, that premium, which I said was $2,200 or so a year, it's higher and meaningfully higher. It could be $2,600 or $2,700 a year instead. So, and this is not publicized. And the same thing is true for Part D, the drug plan. If you don't sign up the first year with one of these private insurance companies that offer Part D coverage, then the next year and for the rest of your entire life, you're going to pay a higher premium. So yeah, Part A, the hospital part, you're supposed to sign up for it, but if you don't, they'll like give it to you anyway. But Part B is not, and D are not so merciful. You're really penalized. So that's a very important question nobody mentioned. Yeah, Ariana, go ahead.
I was going to say something very similar to Zachary, actually. Like, I just thought that as you get older, you might not want to deal with the hassle of having to choose between so many different, like, privatized insurance plans. And if you're, like, like you said, semi-automatically enrolled, it might just be an ease of convenience, even though they don't actually know how, like, they're going to be, like, I don't know, paying, like, higher premiums, but maybe it's just like when you're at that age, you don't want to deal with the hassle of privatized insurance anymore and just having to pick a plan yourself. You're just okay with like what is like offered to everyone at that point. But I actually haven't gone through the process myself personally, so that's just me speaking.
Yeah. Yeah, it's very complicated, and I think there should be more of an effort to get people to go to these area agencies on aging to get help because this is this is really complicated and confusing. I actually one of the I think a talk like James, I think would be really useful to try to give in every community. I mean, all of you by the end, even now you could almost give the talk because you know right now, just based on what you've already learned in like 4 days, you've already learned more than probably 96 or so percent of Americans, and it may be 99 or more. People don't know this stuff. And I don't think many people signing up in Medicare have any notion of any of this. So now that you have this knowledge, and I hope that you'll try to get this information to other people in your medical schools because they know it's never in anybody's curriculum. It's just, I don't know, it's just very strange. Anyway, Ariana, go ahead.
Yeah, I just had a question that came to me as James was talking about like the like over diagnosis and trying to make people like seem more sick. And we read a little bit about the lawsuits that like the whistleblowing lawsuits that came about, but did anything actually change after those lawsuits was my question. Like did they I don't know. Like I imagine they're still doing these practices that we know are like terrible and like only benefiting them, but I guess what was the point of the lawsuits? Like, did anything happen after?
Ariana, I'm sorry, I didn't follow you. I'm not sure which whistleblower lawsuits you're referring to.
Oh, I was referring to the Washington Post article that we read. Um, I'll I'll go back to it and find the years, and you can take Mackenzie.
Is that about the overpayments to Medicare Advantage plans? The cheating?
Yeah, and Kaiser also.
Yeah, okay. Yeah, you're right, nothing happened.
Okay.
There was you saw the Senate study that James referred to in his video. They did a study, they confirmed all that the whistleblowers had been saying, and then, it's lobbying, Better Medicare Alliance and the insurance industry just fighting. You could get on the internet and challenge what I'm saying, but I don't think anything came of it. I encourage you to do that. I don't want to say anything that's inaccurate, but I don't know. I don't know another answer. I'm sorry. Somebody could look that. Why don't you could look it up or someone. Anyway, let us know if anything came of it. Mackenzie, go ahead.
I have a quick question, and I apologize if this is something that was already answered in one of the presentations, but we've talked a lot about how Medicare can still be a significant cost for a lot of people, even after they're enrolled, depending on, how they approach all the, whether they get employee insurance and all that stuff. Have there been studies on whether people are actually spending or how much less, or if they're spending the same than when they were, 64 with a private insurer? Has there been studies in the actual like amount that they pay either out of pocket or with a premium compared to what they pay for their first year on Medicare?
Yeah, I have a slide on it somewhere, and I may end up showing that slide, but I've been trying to cut down the length of presentations, and it pisses me off. The system is so complicated, I can't make short slideshows because everything's so friggin' complicated. I didn't even include the stuff about Plan G and L and K, and then I had to because he referred to it and didn't explain what it was. Anyway, so it's yes, there is a study. The last, and I summarized it in a slide. I may do next week. I just can't remember. And they both came to an average of around $5,400 out of pocket a year for both under 65 and over 65. And that's now a little old, especially for the under 65, because I think under 65 is probably doing meaningfully worse and having to pay more out of pocket. This is not, the whole system's not really stable. The costs are going up at a really high rate, and almost all the extra cost is now being thrown on people for, out of pocket, which I called cost sharing the other day, where people just pay when they need care, even though they have health insurance, deductibles and all these payments. So the last compilation, which I think those data are from around 2019 or 20, before the pandemic, was around $5,500 out of pocket, both for people after Medicare. And that would have included all these, for me, it would have included all the premiums I have to pay. And for a Medicare Advantage payment, it would include all the out-of-pocket stuff they have to do if they actually get sick, since they're not paying as much to get into the plan. So those are the best data I have. You can look that up on the internet, and please, and I encourage you to do that and tell me if I'm wrong, because that's my understanding of it. It ends up at around 5,500 if you combine premiums, their portion, the employee portion of the premium for the younger people, and then their out-of-pocket payments, which are generally high.
So just to clarify, the last study didn't show any financial benefit for people in private insurance versus the Medicare?
Is that a question?
Yes, it was. As I want to make sure I'm understanding correctly, because I feel like I had a very different conception of what that looked like.
I thought you were asking for people under 65 versus over 65. And both
Yes.
groups ended up spending about 5,500, despite, Medicare being there for them. But I don't know if I'm answering your question. So do you
No.
mind articulating it again?
I think that clarified it. Yeah.
Okay. Go ahead, Therese.
So I assume that like new Medicare reform proposals have to do with lower like copays and premiums and deductibles. So I was wondering how that works financially, assuming that the Medicare program doesn't have like too much waste in terms of overhead and profit. Does that make sense?
No, I didn't understand. I'm not doing very well today, I guess. Can you say that again? Maybe.
I guess I'm like wondering, I guess like one question is like what do new Medicare like reform proposals look like? And assuming they have like lower copays and premiums and deductibles, like how does that work financially?
For the taxpayers, the government, how much more would they have to pay?
Like I guess like just to simplify, like what do like newer Medicare reform proposals look like?
Okay, so the uh, effort to reform Medicare gets a lot of discussion, and the proposals range from minor changes, uh, like an interest group like an AARP, which is the big American Association of Retired Persons. That's the big lobby for the older Americans. And they might have little reforms like, giving dental benefits, lowering the Part B premium. They would push for that. So that type of reform, I'll call piecemeal, little reforms. They're just going to they're going to transfer the cost from the people paying the premium, the Medicare beneficiary, onto the taxpayers. So the total cost of all the healthcare doesn't change. They're not taking costs out of the system. They're just transferring the cost from the people, the Medicare beneficiary, to the government. At the opposite extreme, and there's trillions of other proposals going on, at the opposite extreme is, say, PNHP, which is saying to take every single human being in the United States, put them into a single insurance thing, which you could call Medicare, some highly transformed Medicare. They call it improved Medicare. Put everybody in the system, get rid of all the insurance companies, negotiate down drug prices, do a whole lot of other things that can reduce costs. We'll talk about that next week. And then people would pay nothing. Their proposal is for absolutely no copays at all. And then, but the cost to the taxpayer does not actually go up because you're wasting less money. You're not wasting the 140 billion in the exchanges for people under 65. You know, some of that money goes to insurance company profits when we're subsidizing, you know, insurance company, insurance people's premiums to get private insurance. So there's a whole lot of waste going on. And really what the PNHP proposal does is get rid of a whole lot of the waste. You know, next week I'll give a talk on cost control, and you'll see how much waste you could get rid of. Well, and you'll think of more waste when you work. And some of those are systematically happening, and those are the ones that you could get rid of if you change the system. So that's an opposite extreme where you're totally getting rid of costs for people and probably reducing overall taxpayer expense. So there's a real gamut, a huge range of Medicare reform proposals. Does that answer your question?
Yeah, that does. Thank you.